Hello everyone. So today's case is a 30-year-old man who presented with backache, paresthesia, and difficulty in walking. His MRI revealed evidence of a large lobulated hyperintense mass filling the spinal canal and showing subtle signal heterogeneity. And the post-contrast images showed intense heterogeneous enhancement. This is what we received in the lab. The tissue was multiple, irregular, gray white, mucoid, soft tissue aggregating to 3 into 2.5 into 0.5 centimeters. We did squash of this, and the smears showed numerous organized papillary structures, and the neoplastic cells were arranged around the blood vessels and they were showing multilayering. The cells were large, having round oval nuclei with pale chromatin and prominent nucleoli, and the cytoplasm was discrete. Now you can see on the background, this stroma is typical myxoid and it is present along the periphery of the blood vessels. Pathology revealed a tumor composed of cells which are cuboidal to columnar, radially arranged in papillary architecture around hyalinized fibrovascular cords. You can see this various, microcysts of various size and shape containing myxoid material, and this is the distinct feature of the tumor. Mitotic activity is low. Now, there is an entity anaplastic myxopapillary ependymoma. This is an exceptional entity and the tumor exhibits hypercellularity. The mitotic activity is increased. This presence of microvascular proliferation and spontaneous necrosis. Immunohistochemistry uh, reveals GFAP and S100 positivity. Now it is important to distinguish this tumor from metastatic carcinoma, which are GFAP negative and cytokeratin positive. Second DD is paraganglioma. These are typically chromogranin positive tumors. The chordomas show GFAP negativity and these are brachyury positive. And the next differential diagnosis is a chondrosarcoma. Myxopapillary ependymomas are immunoreactive to CD99, cytokeratin, and CD56. The proliferation index Ki67 is typically low, 2 to 3%. These are CAMP5.2, CK7, CK20 negative tumors. The EMA dot-like positivity, which is present in the conventional ependymoma, is usually absent, and these are OLIC2 negative tumors. So, we rendered a diagnosis of myxopapillary ependymoma, CNS WHO grade 2. The 2016 edition, that is the previous edition, graded myxopapillary ependymoma as a grade 1 tumor. But in the fifth edition, it has been designated grade 2 because of its aggressiveness. So the myxopapillary variant accounts for 9 to 13% of the ependymomas. They can be found in all age groups but is common in adults. These patients present with chronic backache and they may be accompanied by sciatica, sensory motor deficits, impotence, urinary or fecal incontinence. And now these are typically or almost exclusively located in the conus medullaris and the phylum terminal. On imaging, these are well circumscribed, multi-segmented, oval, lobular, sausage-shaped masses that usually cause enlargement of the spinal canal and remodeling of the vertebral cortex. These are hypointense on T1 and hyperintense on T2. And the post-contrast T1 images show intense enhancement. The differential diagnosis on imaging is the nerve sheath tumor, paraganglioma, meningioma, and leptomeningeal metastasis. And now the genetic profile is very unique. The DNA methylation profile of this tumor is very unique. Now, these patients carry favorable prognosis in children and adults with 90% survival rate after total or subtotal excision. Myxopapillary ependymomas are resistant to complete removal because of the myxoid nature. Therefore, these patients they live with persistent disease owing to locally advanced growth or CSF bone seedlings. Thank you very much.